Thank you so much, and I thank the National Board for inviting me as a speaker for this talk for the DNB students. And I hope the students will benefit from this talk, because in this I am going to talk on all the latest advances in the diagnosis and management of oral cancer. So oral cancer is one of the most common malignancy in India today and in Southeast Asia as well. So what is oral cancer and what is the incidence in India? Almost 10% of tumors that affect the human body are cited in the oral cavity, and oral cancer is the most familiar form of cancer affecting the head and neck region. And it has a very close relationship with the risk factors like tobacco, alcohol, and human papillomavirus infection. Globally, oral cancer is sixth common cancer, and its burden is increasing markedly in southern countries of Asia, and it is one of the third most common cancers in India. Oral cancer is reported to be fifth most common cancer in urban population and second most common cancer in rural community in Chandigarh. So if we see the status of oral cancer in India, region wise, this is one of the most common cancer in East India, with an incidence of 75.7% in males and 24.3% in females. And after that comes the northeast part of India, with incidence of 58.4% in males, and it has a very high incidence in females as well. Then comes central India, which also has a high incidence up to the tune of 64.8%. And then in the west, incidence is 67.6%. And incidence in North India is surprisingly less as compared to other parts of India. In the south also we see 61.8% incidence in males and 18.5% in females. In North India, the incidence is 58.4% in males and 15.4% in females. So what are the risk factors which can cause oral cancer? The most common risk factors are smoking, cigarettes, bidis, or smoking tobacco, and smoking together, alcohol, and sexually transmitted virus, which is HPV-16. The other factors are environmental and hereditary. So tobacco chewing is one of the common cause for oral cancer in India. And here we can see that tobacco contributes to 49% of oral cancer cases, alcohol to 10%, smoking to 14%, and other factors contribute to 27% of oral cancer cases. So here, this is the picture showing how the oral cancer presents. It can involve any site in the oral cavity. Here in this case, we can see the oral cancer, which is involving the lower lip, and it is involving the skin of the cheek. It is involving lower alveolus here, and some part of the, here we can see ulceration on the upper lip also. And this is the defect after resection of this tumor. We can see there is a huge defect in which lower alveolus has been removed and skin of the chin has also been removed. So this is another case. In this patient, there is a stage 3 tongue cancer, which is involving right lateral border of the tongue. And this is the defect after resection of this tumor from the tongue. So what are the traditional diagnostic aids for oral cancer? Oral brush biopsy uses the concept of exfoliative cytology, and it helps to localize the optimum site for brushing and abnormality in the oral cavity. Conventional oral brush biopsy combined with the application of toluidine glue is used to localize the suspected mucosal areas. So toluidine glue is a dye which stains the suspected area, and from there we can take biopsy with the oral brush. Chemiluminescent illumination technique, photodiagnosis, Bell-scope system, flow cytometry, they help in the detection of oral precancer and cancer by luminoscopy, spectroscopy, or tissue autofluorescence. But these traditional ads are technique sensitive and they may yield false negative results as well. So from where the diagnosis of oral cancer starts, the diagnosis starts from the proper clinical examination. So clinician should do the proper clinical examination of the oral cavity and should be able to predict the diagnosis at the end of the clinical examination. Confirmatory diagnosis is made from various diagnostic ads done in the lab. So this picture shows the various techniques which can be used for diagnosis of the oral cancer. So these are the clinical diagnostic aids. So we can do vital tissue staining with toluidine blue dye, Lugol's iodine, acetic acid staining. The second technique is by biopsy. We can do incisional biopsy or oral brush biopsy. We can take FNSE from the FNSE is fine needle aspiration cytology from the lesion or from the lymph nodes in the neck. Excisional biopsy can be planned for small lesion which is less than 1 centimeter in size. Exfoliative biopsy can be done, and we can do direct oral microscopy, which is also known as colposcopy. The laboratory diagnostic aids include computed tomography, positron emission tomography, ultrasound, magnetic resonance imaging, and nuclear imaging. The recent advances in the diagnosis of oral cancer include various techniques like autofluorescence, which can be done with a device which is known as Wellscope, chemiluminescence with the device called Vigilite, or Microlux DL is another device, or we can do nuclear medicine imaging in the form of bone scan or PET scan. So how we can diagnose the oral cancer in the clinic? We can do toluidine blue test. Toluidine blue is the dye which can be applied in the oral cavity over the suspicious area. Like here, there is a suspicious area in the right buccal mucosa, and toluidine blue dye has been applied over this. So we can see bluish staining of the suspicious area. So we can take targeted biopsy from this area to make further diagnosis of the oral cancer. So toluidine blue, also known as toluenium chloride, is a vital metachromatic dye that stains nucleic acids and abnormal tissues. It has been used for decades as an aid to identify the mucosal abnormalities in the oral cavity, and it demarcates the extent of the lesion prior to excision. So this picture again shows staining with toluidine blue dye, and we can take a swab from the affected area also for diagnosis for cytology. The second method of diagnosing oral cancer early in the clinic is by staining with Lugol's iodine. Lugol's iodine consists of iodine, potassium iodide, and distilled water in contrast to toluidine blue. So Lugol's iodine is retained in normal squamous epithelial cells, but not in dysplastic or malignant epithelial cells. Lugol's iodine solution produces a brown-black stain by reaction of the iodine with the glycogen in the tissues. So normal mucosa contains higher amount of glycogen than the abnormal mucosa and produces brown-black stain. So this picture shows staining of the lesion with the Lugol's iodine, and we see that normal tissue will take up the Lugol's iodine more because of rich glycogen content of the normal mucosa as compared to the abnormal tissue. So we can see this is the abnormal area and this is the normal area. Acetic acid staining in lateral border of tongue. So here is a suspicious lesion in the lateral border of tongue. So there is an ulcer, and we have done staining with the acetic acid. So this ulcer will become more prominent after staining with the acetic acid, and we can take a biopsy from the suspicious area. So what is oral brush biopsy? This technique, although it is old, but one should know how to do the oral brush biopsy. In this technique, oral cells can be obtained by different physical systems of scraping the surface of mucosa, by rinsing the oral cavity, or by taking a sample of saliva from the patients. Oral brush biopsy kit contains Oral brush biopsy instrument, pre-coded glass slide, matching test, requisition form, alcohol or polyethylene glycol fixative pouch in a pre-addressed container in which to submit the contents. The coded test requisition form includes demographic data such as patient's age, sex, history of tobacco and alcohol use, as well as location, clinical description, and category of the oral lesions. So this picture shows how the oral biopsy is taken. So first you have to instruct the patient that we have to take a biopsy from your oral cavity wherever is the lesion. In this patient, there is a suspicious lesion in the tongue, left lateral border. So oral brush biopsy is being done from the tongue, and here it is being done from the buccal mucosa. So this is a special brush which has been devised and patented for oral brush biopsy. All oral CDS slides were stained in accordance with a modified Papani-Collier method. The stained slides are then scanned by oral CDX computer system, which consists of a neural network-based image processing system specifically designed to detect the oral epithelial precancerous and cancerous cells. So after taking biopsy, the tissue is put on the slide, and then slides have to be scanned under the computer. The limitations of this technique is that the existence of false positives have been pointed out, showing high sensitivity and low specificity. The next technique is Wellscope. Wellscope is a portable device that allows for direct visualization of oral cavity. It is being marketed for use in oral cancer screening, and it follows the principle of fluorescence imaging. This technology stimulates epithelial cells and stroma by a blue light of the wavelength of 400 to 460 nanometer. It is a self-fluorescence of the tissues that allows detection of changes in morphology and composition of tissues in a non-invasive manner. So it does not diagnose oral cancer, but this is an adjunct to the examination of the oral cavity. This is Wellscope. This is the instrument, and it uses a light of specific wavelength. And here we can see that this is the abnormal tissue. In abnormal tissues, what will happen? There will be loss of fluorescence caused by epithelial tissue and underlying stromal disruption. But in normal tissue, the light will pass as such through the normal tissues, and there won't be any disruption. There won't be any autofluorescence. Here we can see the fluorescence. So this is a small representative example of the appearance of healthy and suspicious oral tissue under both normal light and Wellscope examination. This is the examination by Wellscope. The next instrument which can be used is Vigilite. It is not a diagnostic tool. It is a screening device. Again, screening for oral cancer can be done that allows the clinician to more easily visualize the suspicious lesions in the oral cavity. Vigilite kit contains chemiluminescent device, 30 ml acetic acid, and light stick holder or retractor. The procedure for examination with Vigilite is that patient rinses with 1% acetic acid for 1 minute. Activate device by bending outer capsule to break the inner vial. Shake capsule to mix the contents and insert the capsule into the retractor unit. We have to dim the room light, visually inspect the oral cavity using the device, and discard the materials after use. So this is how the Vigilite works and what is its mechanism of action. Here we can see normal epithelium absorbs the light and appears dark. But abnormal tissues reflect the light and they will appear bright white. So the tissues which are appearing bright white are abnormal, and normal tissues will absorb the light and they appear dark. The next technique for early diagnosis of oral cancer is contact endoscopy. It is the technique which has a unique capability of demonstrating actual cellular architecture in vivo and provide instantaneous diagnosis of the oral lesions. This technique was described by Hemo in 1979 for visualization of cervical and uterine epithelial cells for screening and diagnosis of cervical and uterine pathology, but now it is being commonly used for diagnosis of oral cancer in head and neck region. The other technique which is also comparatively new, is narrowband imaging. So narrowband imaging is an endoscopic optical imaging enhancement technology that improves the contrast of mucosal surface texture, and it enhances the visualization of mucosal and submucosal vasculature. So here we can see examination of the oral mucosa with normal light, and this is the examination with NBI image. So NBI will give the details of the mucosal and submucosal vasculature, which cannot be seen with normal light. NBI has been used to better assess the oral potentially malignant disorders, identify oral and oropharyngeal squamous cell carcinoma, and to define the surgical margins of head and neck malignancies. The other methods which can be used for early diagnosis of oral cancer are genomics and proteomics. Cancer proteomics provide the identification and quantitative analysis of differentially expressed proteins relative to the healthy tissue counterparts at different stages of the disease, from pre-neoplastic to neoplasia. They are used to identify markers for cancer diagnosis and to monitor the disease progression and to identify the therapeutic targets. So it is valuable in the discovery of biomarkers because the proteome reflects both intrinsic genetic program of the cell and impact on its immediate environment of protein. At the protein level, distinct changes occur during the transformation of a healthy cell into a neoplastic cell, ranging from altered expression, differential protein modification, and changes in specific activity to aberrant localization, all of which may affect the cellular function. So genomics and proteomics is basically study of the oral cancer at molecular level. The other technique which can detect oral cancer at early stage is PCR or polymerase chain reaction. This can be extensively modified to perform a wide array of genetic manipulations, and PCR can be done on oral tissue biopsy samples. It can be done on the blood samples, saliva samples from the oral cancer patients to look for the expression of various prognostic biomarkers of oral cancer like EGFR, P53, VEGF, P16, MMPs, and NGF, etc. All these are the tumor biomarkers for oral cancer. The other technique is microarrays. The microarrays is a new technology in which DNA microarray and DNA chips have been developed that give hundreds to thousands of more genetic information in a shorter period of time than the original PCR techniques. So they can detect tumor in very short time, and microarrays are needed to appropriately classify tumor subtypes, molecular information about the tumor, and can be used in combination with other diagnostic methods to add more information about the tumor specimen by looking at thousands of genes concurrently. Nanodiagnostics is another new technique. The use of nanodiagnostic is cost effective and has increased sensitivity. This tool, the tools in nanodiagnostic include quantum dots, nanoparticles, and cantilevers. The quantum dots are semiconductor nanocrystals characterized by high photostability, single wavelength excitation, and size tunable emission. Barcoding of specific analytics can be done by quantum dots and magnetic nanoparticles. So hence we have a bio barcode assay which have been proposed as a future alternative to PCR. The application of quantum dots being used for tumor detection, tissue imaging, intracellular imaging, immunohistochemistry, infectious agent detection, multiplex diagnostics, and fluoroimmunoassays. The other latest technology for early diagnosis of oral cancer is next generation sequencing, also known as NGS. It is one of the most significant technological advances in biological sciences, and they have advanced rapidly to point that several genomes can now be sequenced simultaneously in a single instrument run in under 2 weeks time. So we can do targeted DNA enrichment methods can be applied here to allow even higher genome throughput. The sensitivity, speed, and reduced cost per sample make it highly attractive platform compared to the other sequencing modalities. Then we can make the diagnosis of oral cancer from saliva also, which is a non-invasive method. And the study of saliva at molecular level is known as saliviomics. This is aimed to highlight the rapid development of knowledge about various omics constituents of saliva, including proteome, transcriptome, microRNA, metabolome, microbiome. The new technologies have validated a wide range of salivary biomarkers that will soon make the use of saliva as a clinical reality. And the technique is known as liquid biopsy. When we study the oral cancer cells in saliva, so it is known as liquid biopsy. This enables detection of circulating tumor cells and fragments of the tumor DNA in saliva, thus enabling non-invasive early detection of the various cancers from saliva. Electric field induced release and measurement, also known as EFORM technique, provides near perfect detection of actionable mutations in lung cancer patients, and these recent advances widened the salivary diagnostic approach from oral cavity to the whole physiological system. So this is the list showing summary of the most common non-invasive methods for diagnosis of oral cancer, oral squamous cell carcinoma, and these are toluidine blue oral brush biopsy, saliva-based oral cancer diagnostics, light-based detection systems, optical biopsy, and biomarkers, and laser captured microdissection. So what was the need for all these techniques? The modern diagnostic techniques are introduced to meet the following objectives: to develop and maintain an oral cancer database and tissue bank, to strengthen the multidisciplinary research culture by establishing a vigorous vital research platform, to prevent and detect oral cancer with advanced validated diagnostic tools at a molecular level, to comprehend the genetic susceptibility of individuals for oral cancer, to predict the disease course by identifying genetic links and that aid in developing personalized medicine and cancer vaccine, and to generate a consortium of comprehensive panel with respect to the genomic abnormalities in oral cancer. So if we see the difference between previous practices and new approach, so there are so many differences. The previous practices used to be in the form of descriptive medicine. With the new approach, we have understanding of the disease mechanism, and previous practices had empirical diagnosis of the disease. Here we have mechanism-based diagnosis and treatment. They were grouped by organ site, here subgrouped by molecular or biological classification. The treatment in previous practices was uniform. Here we can develop individualized treatment. Previous practices used to retrospectively diagnose the disease. With the newer approach, we can prospectively evaluate relative disease risk. And in previous practices, there was acute care, but now here with the new practices, new approach, we can do early detection and intervention. So what are the treatment options for oral cancer? Currently, the extent of surgical excision is determined by conventional cross-sectional imaging modalities such as CT and MR imaging, palpation and subtle visual observations to delineate where abnormal tissue ends and where the normal tissue begins, and use of frozen section pathology analysis for the presence of subclinical disease at the margin. With these technologies, a recent study based on the National Cancer Database from 1998 to 2012 found a pooled positive tumor margin rate for oral cavity cancers of 12.75%, consistent with single institutional study rates of 1 to 22%. So what are the emerging techniques in ablative surgery for oral cancer? The emerging techniques which can help in ablative surgery are intraoperative ultrasound. Ultrasound can be used to map 1 centimeter gross deep clearance and interrogate the final resected specimen for adequacy of surgical margins. Utilizing a braided suture or needle to map out the ultrasound determined deep margin has also been described. Intraoperative navigation is another system which can be used for assessing the tumor margin during surgery. When fused with a planning software, the image guidance systems can be combined with software to virtually plan the resection, including contouring the tumor and defining the margin of resection with the positioning of landmarks within the software. To circumvent the delay between preoperative imaging and the operating room, some hospitals are equipped with intraoperative cone-beam CT scanners, have also been incorporated in the imaging study into their workflow. We can use narrowband imaging intraoperatively to see the tumor margins and to see all the abnormal areas after resecting the tumor from the oral cavity. So NBI is a newer video endoscopic system with narrow band filters that allow the passage of only two specific wavelengths of visible light corresponding to the absorption peaks of hemoglobin. So with this technique, this allows the enhanced visualization of microvascular changes that occur in the mucosal surface and in the submucosa. And we can see the intraepithelial papillary capillary loops or IPCL. And there are various patterns of IPCL which can be seen in various disorders of the oral cavity. So IPCL type 1 are seen in normal mucosa and they appear as regular brown dots. Type 2 IPCL can be seen where there is dilatation and crossing of the blood vessels. In type 3, there is elongation and mindering of the blood vessels. In type 4 IPCL pattern, there will be IPCL pattern destruction and angiogenesis. So optical advances in surgical visualization are also there, which can be used intraoperatively. So epidermal growth factor receptor or EGFR is a tumor membrane bound biomarker, has been leveraged and when targeted with a peptide bound to a fluorescent agent can increase the specificity of fluorescent agents to sub-millimeter resolution. These agents allow for robust fluorescent tumor to normal tissue signal in real time. To account for tumor heterogeneity, a cocktail of receptor targeting agents could be used to increase the tumor to background ratio. So beyond use of a fluorescent marker, researchers have also found using near-infrared wavelengths with specific photodetector cameras allow for deeper tissue penetration, reduced light scattering, and superior sensitivity compared with the preoperative imaging. Currently, there are more peptides and targeting agents undergoing evaluation, including those that aim to target the clinical structures like nerves. So resection of tongue cancer with ultrasound devices like harmonic scalpel and TAUs can be done for better dissection and better. These technologies cause less tissue trauma to the normal tissues. Radiofrequency ablation of the tongue-based tumors and tonsil tumors is a new modality. Transoral robotic surgery for resection of tongue-based cancer and for oropharyngeal cancers like cancers in the tonsils, soft palate, base of tongue, valvula, they can be resected with transoral robotic surgery using Da Vinci robot. NBI guided resection of oral and oropharyngeal cancer is the latest modality with the ability to achieve high negative margins during tumor resection. So other techniques which can improve the resection of tumors and which can help surgeons in better management of the oral cancer are deep learning computer-based software to diagnose oral cancer. CNN or convolutional neural network is a type of machine learning that can be used to enhance pattern recognition, whereby unannotated raw images can be uploaded and classified based on a large data set of pre-classified images. As these algorithms become more efficient and sophisticated, this technology may eventually be capable of guiding the surgeons intraoperatively in real time and assist with recognizing different structures. Most recently, the CNN has been applied to a clinic setting whereby it was found to identify high-risk regions in video sequences of oral squamous cell carcinoma with accuracy of 88.3%. So this was all about diagnostic aids for early detection of oral cancer. Now I will speak on contemporary head and neck reconstruction. So what are the various reconstructive techniques which can help us in better reconstruction of the oral cavity defects? So uh, reconstructing a three-dimensional defect in order to restore both the form and function, shaping and contouring a bone flap that needs to be secured to the remaining craniofacial skeleton with titanium plates while simultaneously manipulating a soft tissue flap can be extremely difficult. When taking into consideration the need to optimize post-operative speaking and swallowing function, restore dental occlusion and prepare dental rehabilitation, and achieving the best overall aesthetic result. The integration of virtual surgical planning, VSP, rapidly prototyping with three-dimensional printing technologies, computer-assisted design and manufacturing, which is also known as CAD/CAM technology, are being integrated into reconstruction complex head and neck defects. This technology can optimize the segmental mandibulectomy and maxillectomy defects. So this is the 3D printing technique where the defect of after resection of the oral cancer can be measured pre-operatively with the help of computerized software, and we can manufacture the surgeon can plan the reconstruction with free fibula graft pre-operatively, how much fibula has to be taken, how much bone is required, and how much of the soft tissue is required, and how many osteotomies have to be done into the bone so that there is better contouring during surgery. So virtual surgical planning is the latest technology. So what are the treatment options for oral cancer? As we see that most of the oral cancer patients come in later stages, and over 80% of the tumors are seen in later stages, that is stage 3 and stage 4. So treatment options are surgery, which is one of the best treatment options available for oral cancer, radiation, radiotherapy, chemotherapy, and we can combine the above. The treatment depends upon the clinical stage, location, and histological type of the tumor. And we have to see the quality of life issues have to be taken into consideration in treatment planning for oral cancer patients. And the issues which affect the quality of life of these patients are like nutrition has to be maintained throughout the treatment. Speech has to be restored, appearance, all functions must be addressed in the treatment planning. So surgery is one of the best treatment options available for oral cancer, and type of surgery will depend upon the extent and location of the cancer in the oral cavity. Generally, we do wide local excision involving removal of the tumor in soft tissue with 1 to 1.5 centimeter margin of clinically normal tissue at the periphery of the tumor. Resection involves removing carcinoma that has invaded bone with a 2 centimeter margin of radiologically normal bone tissue at the periphery. And marginal resection involves resection of bone while leaving inferior border of the mandible intact. Segmental resection means removing a segment of the mandible in which full height of the mandible is removed in one segment. And composite resection involves removal of the hard and soft tissue, typically the neck nodes, mandible, soft tissues associated with primary tumor as in the tongue and floor of mouth. Neck dissections have to be done for, even if we are operating stage 1 oral cancer, we have to do neck dissection. And even if the neck is negative, clinically and radiologically, we have to address the neck because chances of micrometastasis to the neck are very high in oral cancer. And the incidence of micrometastasis is up to the tune of 25 to 30%. So we have to address neck in all cases of oral cancer, whoever are undergoing surgery for oral cancer. The neck dissections can be in the form of comprehensive neck dissections, which include radical neck dissection and modified radical neck dissection, or it can be radical neck dissection where we remove all the lymph nodes of the neck along with sternocleidomastoid muscle, internal jugular vein, and the spinal accessory nerve. The modified neck dissection preserves the sternocleidomastoid muscle, IJV, and spinal accessory nerve. In selective neck dissection, we remove only a selective group of lymph nodes, preserving all three vital structures. And this picture shows wide local excision for a tongue cancer. This is carcinoma involving the right lateral border of tongue here. and wide local excision of this tongue cancer has been done, and this is the defect after resection. So this patient had squamous cell carcinoma of the floor of mouth. Here we can see the tumor involving floor of mouth and adjacent alveolus, lower alveolus. So it is involving the mandible. This is the specimen which has been removed. Wide local excision along with segmental mandibulectomy has been done. So this much segment of the mandible has been removed. And here the reconstruction has been done with free fibula graft. This is the free fibula graft, bone. This is bone and this is the soft tissue. And this is the defect in the floor of mouth which has been reconstructed with free fibula flap, and here we see the complete filling of the defect with the graft. This picture shows squamous cell carcinoma involving the upper gingiva buccal sulcus and upper alveolus. So wide local excision has been done. This is the tumor involving anterior maxillary gingiva and bone, and here we see the defect after 1 month of the resection, and the patient used dentures. So we can ask our maxillofacial surgeons to make a prosthesis for this patient to cover this defect, and now patient is disease free for more than 10 years. So what are the various methods for reconstruction of oral cavity defects? The various methods of reconstruction following surgery are DP flap, deltopectoral and pectoralis major myocutaneous flaps. These two flaps are the most commonly used flap for reconstruction of the head and neck defects. Bone and soft tissue grafts provide good cosmetic appearance and function. Osseointegrated implants and dentures can also be used for reconstruction of the bony defects. Fibula can be used to reconstruct the mandible. So various types of flaps which are used for reconstruction of the oral cavity defects are: the criteria of the flap has to be seen, like in advancement flap. So this advancement flap means there is a linear configuration of the flap. So it is used for reconstruction of defects involving the forehead, helical rim, lips, and cheek. Intraoral uses of advancement flaps include covering the oroventral fistulas and alveolar defects. So this is the advancement flap, also known as Mockjaer buccal sliding flap. Here we can see this is the defect, this is oroventral fistula, and this is the advancement flap which has been taken from the upper gingiva buccal sulcus and buccal mucosa. And other advancement flap is Redman buccal advancement flap. In this also we are advancing the buccal mucosa over this defect which is oroventral fistula, and this flap can be used to cover this fistula. The other type of advancement flap is buccal transposition flap. So here the defect is here, oroventral fistula. So we have to make a release incision here and transpose the mucosa from here to here. So the second type of flaps are rotation flaps. The criteria of rotation flaps is that they have a curvilinear configuration and reconstruct the triangular defect, have a large base, and they have either random or axial in their blood supply. The blood supply is either random or axial. The indications for rotation flaps are reconstruction of the scalp defects. The flap size should be more relative to the size of the defect due to non-elasticity of the scalp tissue. It is used for oroventral fistula closure, which can be used for done with palatal flap. So palatal flap is also a form of rotation flap. For nasal defect closure, again we can use axial frontonasal flap. So this is the palatal island flap, which is a type of rotation flap. Here it is based on the greater palatine artery and composed of mucosa or submucosa to cover the oroventral. This is the flap. So it is based on greater palatine artery. So base will be here posteriorly on the artery, and flap has been rotated into the defect to cover the oroventral fistula. Then buccinator myomucosal island flap can also be used to reconstruct the defect of the buccal oral cavity, and blood supply is facial artery. Then third type of flaps which can be used in head neck defects are the transposition flaps, and criteria for transposition flaps is that these flaps are rotated and advanced over the adjacent skin to close a defect. They are designed so that one border of the flap is also a border of the defect. The advantage of transposition flaps is that they transfer tension away from the closure of the primary defect. And these flaps can be used for reconstruction of nasal tip and alar defects, inferior eyelid defect, and defect of the lip. Then we can use interpolation flaps, and various types of interpolation flaps are nasolabial flaps for reconstruction of maxillary alveolus and lip commissure, reconstruction of lower third of the nose, reconstruction of chin and columella. Blood supply of the nasolabial flap is angular artery, infraorbital artery, and infratrochlear artery. This is the nasolabial flap here. This is the defect. This is the nasolabial flap which has been harvested, and it has been used to cover the defect. The other type of interpolation flaps is the lip switch flap or Abbe flap. Here, tumor was in the lower lip. So after resection of the lower lip, this was the defect in the lower lip. This same size, we have to measure the size of the defect, mark it here on the upper lip, and then remove the full thickness of this area, this wedge of tissue, and rotate it down into the defect. So primary donor side defect can be closed primarily, and this is the flap. Tongue flap is also interpolation type of flap. So here tongue flap can be used for reconstruction of the defects in the palate, like cleft palate, and for reconstruction of defects of the oroventral fistula, here defect in the upper alveolus. So this is tongue flap which has been used for reconstruction of the oroventral fistula. Here tongue flap is being used for oroventral fistula. Now coming to the regional flaps. Free mycocutaneous flaps are the most commonly used regional flaps, and these include cervical island skin flap, lateral thigh flap, radial forearm free flap, lateral arm osteocutaneous flap, jejunal free flap, fibula free flap, scapular free flap, iliac crest free flap, rectus abdominis free flap, clavicle bone flap, and sternum bone flap. So free flap, what is free flap? Free flap has its own vascular supply, own arterial and venous supply from the donor site, and that those artery and veins have to be anastomosed to the recipient site. So you have to anastomose artery with the artery, vein with the vein. Radial forearm free flap is the commonly used free flap in head and neck, and blood supply is from the branches of radial artery. It is used for reconstruction of soft palate defects, tongue and floor of mouth defects, anterior maxilla, and non-tooth bearing areas of the mandible. The lateral arm osteocutaneous flap is based on radial collateral artery. Jejunal free flap can be used for reconstruction of the pharyngoesophageal defects. So when there is a total defect in the pharynx after total laryngopharyngectomy, so jejunal free flap is a very good flap. Oral cavity, oropharyngeal region, tonsil, soft palate, base of tongue. All these defects can be reconstructed with jejunal free flap. Fibula free flap is based on peroneal artery, and it is used for reconstruction of the mandible. Fibula allows placement of the osseointegrated dental implants also. Scapular free flap can also be used for reconstruction of the defects in the maxilla, defects of the orbit. So it is based on scapular artery, parascapular artery, and dorsal thoracic artery. The complex defects involving skin, bone, and mucosa of the face. So scapular free flap is a very good flap for maxillectomy defects specifically. Iliac crest free flap can be used for reconstruction of the lateral and hemimandibulectomy defects. Rectus abdominis free flap is based on deep epigastric artery, and this is used for reconstruction of the posterior part of the mandible, large tongue defect, defect of the orbit, and cheek defect. Clavicle bone flap can be used for defects in the face, and sternum bone flap can also be used. So these are all free flaps. Now coming to pedicle myocutaneous flaps. So pedicle myocutaneous flaps are pectoralis major myocutaneous flap, which is the most commonly used flap for reconstruction of oral cavity defects and any defects in the head and neck area. Deltopectoral flap, temporalis flap, sternocleidomastoid flap, trapezius myocutaneous flap, latissimus dorsi myocutaneous flap, and platysma flap. So this chart shows the comparison of soft tissue flaps for buccal mucosa and tongue reconstruction. So every flap has its advantage and disadvantage, but if we see the best results are when there is a defect in the tongue. So best result can be obtained with free flaps like radial forearm free flap or lateral arm free flap or anterolateral thigh flap. Tongue defects and options available for reconstruction. If there is hemitongue defect, then we can use radial forearm free flap. If there is subtotal defect of the tongue, like 2/3 of the tongue, if there is a defect of 2/3, bulky skin flap is required. Anterolateral thigh flap is best. 3/4 of the tongue defect can be reconstructed with ALT flap, and total tongue defect are reconstructed with, again, ALT flap. The latest flaps for oral cancer defect reconstruction include submental flap, infrahyoid flap, and supraclavicular flap. So this is the submental flap, which is based on submental vascular pedicle. Submental artery is a branch of the facial artery, and this is very useful flap for reconstruction of small defects in the oral cavity and in the tongue. So it can be harvested by the ENT surgeon or head and neck surgeon himself without the help of plastic surgeons. And here we can see how nicely the defect has been reconstructed in the tongue. Infrahyoid flap is based on superior thyroid vascular pedicle. This is the infrahyoid flap, and we can harvest up to 9 into 4 centimeters of the area, and this flap can be rotated into the oral cavity. Supraclavicular artery island flap based on transverse cervical vessels. So these are the transverse cervical vessels, superficial transverse cervical artery, and these are supraclavicular branches, and we can harvest this flap, supraclavicular artery island flap. This can be rotated into the oral cavity for reconstruction of defect here in the oral commissure. So we can do reconstruction with advanced prosthesis also. So if we have the provision of prosthesis, and if we can get very good prosthesis, then defect can be reconstructed with prosthesis. Like here we can see the woman who had a large midfacial defect. First figure shows the tissue bars in position. These are the tissue bars, and header bar retention system was used for retaining the prosthesis. Second picture shows the completed prosthesis. This is the prosthesis, including the eye also, nose also. So this is whole prosthetic device. In the third photograph, the prosthesis is snapped into position. So here we cannot make out the difference between the normal and abnormal site. So again, here we can see a midfacial defect of the upper alveolus, reconstruction with the prosthesis. This is the prosthesis replacing the maxillectomy defect, and this is the prosthesis replacing the defect of the nose. The other treatment modalities which are available for oral cancer are radiation therapy. So we should know the recent advances in radiotherapy, which include IMRT, IGRT, SBRT or gamma knife, ISRT, proton beam therapy. IMRT is intensity modulated radiotherapy. IGRT is image guided radiotherapy. SBRT or gamma knife is again computer based technology. And ISRT is brachytherapy or interstitial radiotherapy. Proton beam therapy, again very sophisticated and very targeted type of radiation therapy. So radiation therapy can cure small lesions, T1, T2 lesions, like this is T2 lesion of the lower lip. And here we can see 1 month post radiotherapy, the lesion has disappeared. With radiotherapy, again oral cancer involving the buccal mucosa on right side. Here, this is the result after treatment with radiation therapy. Brachytherapy can be used for small T1, T2 lesions in the lateral border of the tongue. So we have to select the site for brachytherapy very carefully, because in brachytherapy we have to insert the needles into the through that tumor, and these needles are loaded with the cobalt. So this is the result after brachytherapy. There will be ulceration of the mucosa and disappearance of lesion, and here we can see the result, no evidence of tumor. So the advantage of brachytherapy is that tumor has gone and we have preserved the function of the tongue also. So functional preservation is one of the most important aspect of non-surgical treatment. This is the telangiectasia and mucosal fibrosis which occurs after radiotherapy or after brachytherapy. The other side effects of radiotherapy is osteoradionecrosis. Here there is osteonecrosis of the mandible after radiation, and once the osteonecrosis has set in, we have to remove this segment of the mandible which has necrosed, and we have to replace it with a bone graft. Then there are advances in the chemotherapy also. Chemotherapy, the advances are in the form of neoadjuvant chemotherapy, which means chemotherapy being given before radiation. Concurrent chemotherapy is the chemotherapy which is given during irradiation, and adjuvant chemotherapy means chemotherapy after irradiation. The other advances are targeted therapy with cetuximab, which is monoclonal antibody. So it will target only few tumors which have positive EGFR expression. Immunotherapy is the latest advancement in the chemotherapy for head and neck, and immunotherapy drugs which are available are nivolumab and pembrolizumab, etc. The most commonly used drugs for head and oral cancer are paclitaxel, methotrexate, bleomycin, cisplatin 5-FU. The other research includes the use of intra-arterial chemotherapy and intralesional chemotherapy. The summary and take-home message from my talk is that treatment outcome of oral cancer in recent decades has compellingly improved with the advancement in reconstructive surgery and adjuvant treatment. The recent focus of treatment remains on improving the patient's quality of life. Further improvement in prolonging survival is hampered by an increase in the second cancer incidence in long-term survivors. With this in mind, the oral cancer prevention is the first step. Following that, a requirement of enhancing awareness, promoting education about oral cancer detection, improving lifestyle of the patients, and developing early diagnostic tools should have high consideration. Thank you all for patient listening.
Thank you very much, Professor Dr. Jaimanti, for the presentation. Trainees, you may type your questions, comments in the chat box. Dr. Nilima, welcome.
Yeah, thank you, Mr. Navneet. Dr. Jaimanti, thank you so much for the talk about the recent and the latest advances in oral cancer diagnosis, management, reconstruction, and also the important advances in the radiotherapy and the chemotherapy. Definitely, it has improved the outcomes in this highly prevalent oral squamous cell carcinoma that we have, especially in India. The incidence is a lot about the oral head and neck amongst the head and neck cancers.
Yes, ma'am. Thank you so much, ma'am. Thank you.
So I think, do we have any questions? Dr. Jaimanti is professor and unit head at PGIMER Chandigarh, and one of the students wants your email ID, ma'am.
Okay. Let me see the chat box. 1 minute. Yeah. So I should put it on the chat box. I
Maybe
should.
you can, yeah. So, Dr. Jaimanti, do you have any experience with the salivary markers such as the lactate dehydrogenase? Uh, do we do?
Yes. Yes, ma'am. We are doing salivary markers evaluation here, but we are testing for MMPs,
Okay,
matrix metalloproteinases in
metalloproteinases.
saliva, and
Okay,
other proteins like cysteine and all.
okay,
And we are studying microRNAs also in the saliva of oral cancer, suspected oral cancer patients. mRNA, microRNAs.
micro RNA. Okay,
Yeah,
yeah.
yeah.
Okay. And you have also used the oral brush biopsies because
No, we have not used it
we
because
rarely find available. Yeah.
yeah, it is not easily available. We will have to. It has been patented by somebody, so we have to order it, and it can be used for screening of the oral cancer in the camps where we have to do screening in a larger population. But now
Yes, as a
in our
screening
clinic,
measure. Yes.
yeah, it can be used for screening for oral from the suspicious lesions in the oral cavity.
Yes. So one of the questions is whether the liquid biopsy is used for recurrent cases, residual cases, or as a primary diagnostic aid.
Yeah, liquid biopsy can be used as a primary diagnostic aid in suspected cases where we see a lesion in the oral cavity and we are not sure about the diagnosis, and if the patient is not willing for biopsy. So in that case, we can do the liquid biopsy, but it can be used in residual cases and recurrent cases also for early diagnosis of the recurrent or residual disease.
Yeah, basically these are non-invasive investigations or diagnostic aids found easily, and at least we start for the physiological difference, then we will have to go for the biopsy. So, but still,
Yes.
in the primary cases, I think it will help us in not losing time. It will be
Yeah.
efficient
So
diagnosis, I think.
yeah, with liquid biopsy, we can detect circulating tumor cells in the saliva. So
Mhm.
that those circulating tumor cells can be seen in the patients who have been operated earlier, who have already been treated for oral cancer, and they can detect early recurrence also in some patients. If we find circulating tumor cells in the saliva, but we don't have any evidence of the lesion in the oral cavity, so they can those cases can be picked up early. We can do other tests like PET-CT for early diagnosis of the recurrence in those cases.
There's one more
So,
question from
Dr.
Dr.
Uma,
Uma.
have you joined us today? So, there's a question uh, how would you compare the liquid biopsy to other methods as far as the results are concerned? What would be, I think the person wants to ask whether what is the sensitivity and specificity of the the liquid biopsy?
Yeah, sensitivity of liquid biopsy we have seen here is up to the tune of 80 to 85% sensitivity.
Okay, that's quite good.
Yeah.
Mhm.
So it is
Yeah, maybe we must be getting false negatives, but
in up to 20%,
sensitivity is
we need
quite
to.
good.
Yes, ma'am. But
Yeah.
gold standard remains the biopsy only. So liquid
Biopsy, yes.
biopsy is for early diagnosis of oral cancer, basically, where we have a suspicious lesion in the oral cavity and we are not sure about the cancer, whether this patient has oral cancer or not. So circulating tumor cells can be seen even before we see the frank tumor in the oral cavity.
So thank you very much, Professor Dr. Jaimanti Bakshi, for the presentation, and thank you very much, Professor Dr. Nilima Gupta, for joining us. And thank you, trainees, for joining us.
Thank you.
Once again, Dr. Jaimanti. You agreed for this talk at a short notice. That was very nice of you. Thank you. Thank you so much.
Thank you, ma'am. It was my pleasure interacting with you, all of you. Thank you so much.
Thank you.